Okay, so today's quality leader session, we're going to continue on with our focus, our monthly reviews on some of our top citable regulation or high risk regulation that we have within our guidance from the SOM. Before we get into accidents and showing my level 10-year in skilled nursing, I still recall it being access to supervision. It's now F689 accidents. We'll go through what we're doing right now, what the current public health emergency and current COVID counts look like. So first, we have our up-to-date status with COVID vaccinations. Looks like we're still doing a nice job on getting the vaccinations administered, those boosters up to level. And if you hadn't seen it yet, the ACIP met this week and also made recommendations to do an annual booster bivalent. So that's the group, FDA group, an advisory group that met in January, and the ACIP met in February, both groups making those recommendations. We look forward to seeing what that will come about, but it's a hopeful feeling as we look ahead, seeing that there might be a manner in which we can keep things a little bit more streamlined and less confusing as the last couple of years have been with boosters and trying to educate our families on this. COVID counts continue to decrease. We had a little bit of a bump up this week of February, ending February 19th, but still we're at 108 current counts and a 7.0 COVID rate. It feels really good to see all that green in the community transitions for COVID in South Carolina. And then looking at the transmission rates as we're planning out and preparing for mitigating initiatives that we have, whether they be increased cleaning, increased rounding, upping our masks from surgical masks to N95s, as you see fit based upon what we have happening in the transmission levels. But we've got a couple counties that have already moved into the moderate, so we're moving from all red and starting to get into the oranges and yellows, which is wonderful for spring. And the public health emergency update. So initially, the Department of Health and Human Services released information on February 9th, following the January 27th announcement from the White House. And so this is the link that talks about some of the enrollment criteria, what we see happening with the guidance on how we're transitioning to public health emergency. And as predicted, there's going to be more information coming through as we go the next upcoming weeks. So this week on the 27th, CMS updated their PHE pathway sheet, this fact sheet that can give you information on what the waivers are looking at, where they're expiring, and some of the additional clarification points that they've been able to update since the last review. So I definitely want to ensure that you have the opportunity to take a look at that if you haven't seen it yet, and make sure you're reviewing it through a copy process with your interdisciplinary team, because as we recognize, many of our public health emergency initiatives had reached into multiple departments, from admissions and billing to nursing, infection control, maintenance. So you want to ensure that your team is reviewing these to verify that you're where you need to be going forward and transitioning through the upcoming dates. Okay. So on to our review of access and supervision. So I did some research to take a look what the national rates are in the South Carolina rates for citations relating to F689. And if you recall, we had the change in guidance in the SOM updates in 2017 coming in 2018. So I can't get historical data before that because the regulation has changed and modified. But since 2018, we've seen I would say it's a pretty consistent level of citation with 689 being accidents. Even though it's there is a component in there with ensuring that we have staff to supervise the residents to prevent and limit accidents occurring in the organization. 2023 is year to date. That includes anything from October forward as it's been currently published and care from here. So we're still a little bit behind, but to keep it in reference points of what our time frames are looking like. Looking at the scope and severity in alignment with the number of citations that we had in South Carolina. I'm sorry, I should explain previously, these are percentage points. So it's running, approximately between 12.5% and 18% of the facilities are getting cited for 689. And nationally, it's running between 20 and 32%. So it's a pretty big citation that we see, a common citation that is being administered or issued in skilled nursing facilities. This is the actual counts that we've seen by year, and the orange line is those current counts that are harm level, so anything at a G level or higher for scope and severity. It's important to recognize that the psychosocial grid comes into effect in October of 2022. So this is the 2023 year-to-date bucket. We're going to start to see that psychosocial grid potentially influencing the number of harm, because it's going to cite harm on what the person is feeling or experiencing. So running between 34 and 52 citations annually within South Carolina. This includes both annual surveys and complaint surveys, as well as any infection control surveys that were completed during the pandemic. And then the scope and severity, we're seeing that we're starting to narrow the gap, meaning as we progress from 2018 to current, we're seeing that there's more harm level citations. The percentage of citations that are harm level of the total issued is getting tighter or more than we've seen in the beginning of the start. So it is something to keep in perspective. Last year in 2022, there was 40 citations issued. 24 of those were at a G level or higher. This year to date, we've had 6 citations issued at 689. 5 of those have been at G level or higher. So let's talk about what 689 means. 689 was initially issued in was updated in October of 2022 and issued out with this update on February 3rd, 2023. The guidance is that the facility must ensure the resident environment remains as free of accident hazards as possible, and each resident receives adequate supervision and assistance devices to prevent accidents. That guidance goes further into giving us information, examples, and even the interpretive guidance on how to cite for the harm level, scopes, and severities. But generally speaking, our process flows from the review of the surveyor, from a review of the regulation. It has a cyclical process. The guidance is looking to ensure that we're identifying hazards and risks, both at initial and periodic and with changes in conditions, so that we have that review. And excellence in supervision isn't just related to faults. It can be multiple levels of accidents, as we're aware. And so we want to think about what those ongoing evaluations of hazards and risks look like. We want to evaluate and analyze what the hazards and risks are. We want to implement interventions to reduce the risk. And this can be from care planning or rounding or audits or creating a culture of awareness and being mindful of what our needs are. We want to monitor the effectiveness of our solutions or interventions that we put into place, and then modify the interventions as appropriate. And we want to take credit for that in our QAPI process. We recognize that QAPI, then the quality assurance program, was also a citation that was updated in October. And so bringing this all together, pulling it together, helps us to ensure our program is ready to be compliant and that we're identifying what those opportunities are. The cyclical process on the survey guidance really mirrors what we see from the ADP model for nursing, or even the quality PDSA or PDCA model, where we're doing our analysis, we're evaluating the facts, we are putting our plans into place, we're assessing or evaluating what the effectiveness of the plan was and making adjustments as necessary. And that keeps that cycle going. So if we keep this in bite-sized pieces, and for our team, when we're leading our teams through these, if we're able to communicate in a manner that relates to something that we already know as standards of practice, it's easier to apply. It's easier to implement, or to be able to feel like you have a handle on the situation. When you step back and look at the significant amount of guidance that we have in the SOM, it can be overwhelming. So bring it back down to those bite-sized pieces. Let's take a look and see How does this flow? What is that nature that we look at, and how do we really implement that into a culture in our organization? The survey pathway, which is what the surveyors use when they come on site, is going to follow a very succinct methodology, and this helps our teams to understand what to expect. We've, the last couple of years, we were really focused on infection control. We had infection control surveys, and it's our time to really get back in alignment or refocus back on what was old is new again. We're going to go back to what those standards look like. And so empowering our staff and understanding what to expect during survey and practicing that with them helps them to feel more at ease and more calm as we navigate our visitors coming into the building. It's also good to have you feel that sense of empowerment when you know what's to come or what they're going to be looking at. It allows us to have a better handle on the situation and reduce that stress that we feel, which is not only good for us as caregivers, but it's also a benefit for our residents and our families. They're going to feed off of what our emotions are. So the calmer we are, the better we feel, the better they're going to feel, and the better improved outcomes we have as a whole. So initially, when surveyors come in, they're going to start with observations. They're going to have the team lead meet with a representative of the center, go through what the plans are and what's needed for documentation. And the remaining surveyors are going to be doing rounds through the building, being present and being able to identify areas that they want to follow up on. They're going to look at things like accident types, and they may ask for incident reports. They're going to want to talk to families and residents. They're going to interview them on specific questions. Then they're going to follow up with staff and interview with the staff. Then they'll lead them into a record review. And in that record review, not only with the medical record and electronic medical record as we have implemented, but also with the incident reports to document or to verify the pieces that are necessary are documented in the records as appropriate. And that's going to lead them on the survey pathway to potential areas of consideration for citation. Just because you end up in a box does not mean that the surveyor will automatically cite you on that. It just is an area for them to consider. The surveyors will then meet together. They'll talk about the citations. They'll run their own quality assurance process. And then we get the 2567 reported to us with our results and the documentation or evidence to support what their findings were. So digging into the survey pathway a little bit further, please remember that the survey pathways are available on CMS for each of us to have. And as a quality assurance process, we should have a calendar developed in our organizations of how we're going to randomly audit these different pathways on a sample population or sample charts, just to ensure we're identifying those opportunities for improvement. When we identify those, we can document a compliance plan. You can follow like you would do for a regular plan of correction. Identify those at-risk residents. Identify the residents in the population that may also be included. Review your systematic processes and take a look at what you might need from education or policy review. Develop your audit tool and review your audit findings with your quality assurance committee to ensure ongoing compliance is maintained. Set your date for compliance. And so you want to see what your monitor is going to be. As with any quality improvement initiative, we want to give a certain amount of time to get the practices in place, get our habits built, and mentor our staff through that process. Then you have your compliance point. When you collect data after that compliance point, you're able to see if you're making the change in the process that is going to necessitate that improvement area that you planned out. If you're not seeing that change, then as before in our cyclical processes, we go back around, we take a look to see what we need to modify or change or adjust. We do those changes, educate our staff, do the monitoring and rounding, complete the auditing process, and then determine if we've made that effective change. The positive on this is not only does it give us that control of being able to regularly assess, we can bring team members into this process. Some of your influential leaders on the floor, they don't have to necessarily be in a position of authority, but your leaders that are encouraging and guiding and are speaking out for their teammates, bring them into this process and have them help do some of these audits. It increases their knowledge and their awareness, helps to share that mentorship and that practice across the board. And most importantly, it starts to educate people on what the environment that we work in. It's, I'd like it back to when I first saw when I went to my first hockey game. Being a from Michigan, so hockey is a big thing in our great state. And when you first see hockey, it's hard to figure out what the rules of the game are. But once you understand what the rules are, once you understand what the intention is, then you can start to see the strategy that people are applying and how to navigate through that game. And I think that's the same thing when we look at how we manage the survey regulations, helping our teams understand what the guidance looks like and what the strategy looks like and why these things play out and why they're rooted in standards of practice that we're all used to, that we're trained on or certified on. It helps to give that comfort level and builds that survey readiness at all times. So our Exit's critical element pathway is utilized in surveys. Surveyors are going to use this for every observation or every chart review that they use. They're going to start with reviewing in advance to the actual interviews. They're going to look at the current MDS and any previous MDSs for the identified population sample. It's interesting, they're going to focus on section C for cognitive patterns, section E for behavior and impact on others, including wandering, section G for functional status, H for bowel and bladder, J for health conditions, O for special treatments, and P for restraints and alarms. So we have an idea of what they're looking at on the MDS and how that flags us through. Then they'll look at position orders and progress notes, and if available, they'll look at any incident reports that are attached to this. And they'll also look at diagnosis and care plans. It's interesting when you look at the critical element pathway, anything that's in red is a new update to the tool. So there's a lot of focus on the use of electronic cigarettes within these our organization, what our policies are around it. So take a look at what those processes look like in your organization. And if you're ready to, if you have a good standard of practice on electronic cigarettes, then they'll look at the observations that they noted during their walking rounds. What type of supervision is provided to residents and who is supervising? So where are your staff located? How are they being, what's your staffing patterns look like, or how are they designated? The number of rooms, or the number of acuity of the rooms that they have. How are care plan interventions being implemented? And what's the knowledge that people have of those? For wandering and elopement, they're going to go down a path on was wandering behavior observed by anybody while they were doing their walking rounds. The smoking and electronic cigarettes observations definitely digs into your smoking policies. For residents and resident altercation and observations, they're going to determine how staff supervise or respond to residents' behavioral symptoms, such as anger, yelling, exit seeking, rummaging, disrobing. For fall observations, some of the things you're going to consider would be how staff respond to the residents' request for assistance, which is going to go on call light responsiveness and timeliness. If staff are doing rounds and doing checks, we used to call them checks and change, where you're doing a routine checking on your residents, what that looks like. And then also looking at what effective interventions are implemented to prevent falls. Are we seeing things in the resident's room, like the resident has a low bed, or that the resident has positioning devices, or mats on the floor, or signs on the wall? These are all components that would be part of the fall prevention measures that are in place for residents. When we're using some of our safety devices, we also have to consider entrapment and safety observations. So the safety devices that we have in place, are we routinely assessing our residents to determine if they're appropriate? One of the things that I've been cited on a few times in my career, and thankfully not at any harm outcome, was not recognizing those slow declines in condition changes. And I think that that's an observation when we think about safety devices and limiting the safety devices to what is necessary for the resident's need and condition at that point in time. And so I think about a resident that was on hospice that was with us for a long time. This particular resident initially had dementia with behavioral disturbances, a lot of wandering, aggressiveness, a lot of falls. With poor safety awareness, was up out of the bed really quick. It's a fast mover. And so we had interventions in place, like a low bed and mats on the floor. And he had a beveled mat for walking. And he had an alarm in place. This was a few years ago. And we didn't recognize that his condition had had been such a slow decline, and we're still so concerned about any injury that he may face, that we didn't recognize that he wasn't ambulatory, and that he wasn't jumping up that much. We were still in that mindset of, well, if he does, we're going to keep him safe from it. Well, he had progressed through that process, was on hospice, and wasn't going to be in that type of mobility any longer. And I think, the surveyor was challenging us on, do you really need to have a fall alarm on this person because they're not getting up? And is the format appropriate for this individual now? Because, are you seeing them rolling into bed and they may roll out of bed? Is there a different type of intervention? So it was a rough citation to have, but it was a good conversation to have with the surveyor of helping us to refocus and think, how are we using our systems internally to be able to identify these changes in condition, these slow declines? And that might be looking at your MBS data or your QIs and QMs, running your I think it's your 672 report. I think it's your 672. Just to kind of see what we're seeing in those changes and identifying those residents, incorporating that into your quality assurance process improvement meetings to recognize that and huddle back together with your team on how we adjust those safety interventions for what's necessary at that particular time. It's almost easier for us to catch those increases in movement or patterns when people are more active than it is to catch the declines. Then we also want to consider the environmental hazards analysis. And so again, it's not just about accidents, meaning where it's a fall or an entrapment. It's also about thinking what other things are in our environments that may create an accident or potential issue for an occurrence or even pain. So we want to look at our handrails. One of the things that I got in the habit of doing is when my walking rounds is just grabbing a couple of handrails, and I went down just to make sure that they were steady and they weren't loose. Making sure that they're free of sharp edges, or looking at how we're storing chemicals, and are our chemicals labeled appropriately, and do our staff have the appropriate goggles to be able to and safety equipment to when using those. Again, in my career, we got a citation for accidents and supervision at that point in time because we were inappropriately storing staff food and drinks next to chemicals. And so our surveyors, rightly so, educated us on what the potential hazard was to our staff. And that led them into our staff break room, where we sealed that citation off rather well. Some good documentation. So good learning opportunity of broadening that accidents out. It's not just for our residents, it's for our staff, it's for our visitors, it's for our family members and our vendors, ensuring we create a safe environment. Ensuring that we have, not only that we have hot water, but that the hot water isn't too hot, and checking the temperatures and have a process in place for looking at those. And lighting. There's some really nice opportunities that we have with lighting changes in what we've seen with technology changes at this point in time. LED having lighting options from different color scales, warm or cool colors, can really brighten up different spaces and help to allow for good movement and support for residents. And also just ensuring that we don't have any burnt out lights in the building that can limit our residents' ability to navigate. Ensuring our assistive devices and equipment hazards are routinely assessed and identified, and creating that culture with our staff that while they're doing their tasks, such as cleaning or installing or moving equipment, that they're assessing that too and recognizing those devices that need to be addressed before we put them back into service for our residents. When we look at moving into the interview status, I think that it's really important that we think about what does our residents know and what do our families know. And so when I interview the family, when the surveyors interview families, they're going to be asking questions, in this case about smoking. Do you know where the designated smoking areas are located? When you talk about wandering, how is the facility keeping the residents safe? When they're talking about resident-to-resident altercations, have you had any confrontation with another resident? Have you observed anything that's concerning to you? thinking on falls, if the resident has fallen in the facility or the family knows about the fall, what were the person trying to do during the fall, and what has staff's interventions been for it. Any other environmental hazards, if you've had any concerns based on specific environmental hazards identifying during the observation. So if they see something, they'll ask the residents or the family, did you have any concerns about this area? So looking at what our communication flows with our families look like, and not just during accidents, but ongoing education or ongoing conversations and the ongoing documentation of those conversations, making sure our grievance process and complaint process is in place, so that we're actively gathering that information to analyze the situation, implement the appropriate interventions, and following up with our families as appropriate. Concern forms or grievance forms is a great manner in which to be able to prove that you've had a conversation documentation, supporting those conversations with your families. Going into staff interviews. The staff interviews are not just limited to the nursing department. There are sections on nursing assistants, on nurse interviews, therapy and restorative, if you have a restorative program in place, and social work. And there's a common theme that we see in all the questions that are being asked. If you had any concerns, have you shared them, and what was the outcome on them? So our communication systems with our staff should be reviewed, and how we're flowing that communication back and forth. How are we seeking out the information from our team members, and based on what our activities or our interventions are, how are we then disseminating that back? And so it's a flow back and forth that we keep those open doors and open lines of communication, so that we're all talking about what those needs are. A big frustration that I've experienced in a couple different facilities has been where you'll hear a staff person say, well, that's been a problem. It's always been a problem. And remember my first survey as an administrator in training, we had a staff member was asked by a surveyor, how long has this door been broken? And the staff member said, looked at us, and you're kind of like nodding, like you have to tell them how long it's been broken. Oh, it's been broken for months. Well, did you tell anybody about it? Yes. And so afterwards, when you have the conversation, we found out in talking with the staff member, well, who did you tell? Well, everyone knew about it. Okay, but what is maintenance aware? I'm not sure. So it's a good opportunity to root cause into that communication system and communication flow, to refocus on, do people understand where to report these concerns to? And just because I'm reporting it and hand off to the person that's coming on the next shift after me, which is wonderful, are we including that into the unit manager or to the appropriate person that can make those changes? So reinforcing those communication flows on an ongoing basis. Some of the other questions that they'll ask is, especially for nursing and nurse aides, is when did the accident occur, if you're aware of one? What were the circumstances around the accident? Did the resident sustain an injury, and was the nurse notified of this? And for the nursing, what did we do for interventions? Did we notify the physician and family? What was the monitoring that we were doing on this? These are good pieces to just reinforce and contemplate how you are doing your investigation and follow through after occurrences and accidents. We'll get a little bit more into that on how huddles can be a solution for that practice if you are not using them now, but also opening that conversation up to see what you are using. And then when we go into the record review, we want to ensure that whatever documented in the records is reflective of what the needs are of the of what you found in the investigation. So we want to know that there's been an assessment done and determine the routineness of the assessment, identifying if underlying risk factors have been identified and documented, and what those look like from a care planning and intervention perspective, what preventative measures were in place and how we were monitoring them. Even if it's not a resident specific occurrence like a fall or wandering, think about this from a elopement system or wander system audit perspective, verifying that we're doing door checks and the doors are functional, the alarm systems are functional, and that the codes are contained and they're safe. Think about what we're doing for hot water checks, or how we're checking beds and how we're checking mattresses. There's a lifespan on the equipment that we have. We know mattresses are generally at 10 years, they need to be replaced, if not sooner. And so how are we looking at these mattresses? How are we looking to make sure that they're not slipping or sliding? Those are additional audit tools that we have in place that we incorporate and utilize, that is documentation to demonstrate our efforts in creating a safe environment. We want to look at any injuries that did occur because of the accident, and ensuring that that's in the medical record with our follow-ups or treatments being done accordingly. And if there was concerns identified, to ensure that we're looking at our policies, because we know the surveyors are going to. We're looking at our policies and we're looking at our procedures and following through, or doing education or adjustments as necessary. So our approach really looks at, looking back at our cyclical process and looking at how the survey and the SOM is written. It really focuses on ensuring our assessment and evaluation steps are in place. We're preventing accidents from happening. We're communicating, have strong communication systems across our teams, across shifts and departments. That information is flowing back and forth between the levels. It's not just kept at the department level or within a specific team, but it's also flowing through your interdisciplinary teams. And that when things occur, that we're doing an investigation to determine what the root cause of this was, to implement a plan to prevent this from occurring again. When we have those documents, our audits or our root cause, or if we take this as an opportunity to do our own internal plan of correction, when survey comes in, we can produce that to the surveyors. And in some cases, we may have the ability to demonstrate that we've changed the process and have had such a positive outcome with it, that we may avoid a citation completely. So kind of keep that in mind on how we can utilize that to promote the work that we're doing, or recognizing our own opportunities. One of the tools that we have, and again, it's kind of bounce backs onto the what is old is new again approach, is the all-cause harm prevention in nursing homes. This document was released in November of 2018 when we started to do the SOM updates and changes. And it's a good reminder tool to kind of help us flow through. In this case, I was looking at falls because falls tends to be one of the higher risk areas. It's not the highest. We still have resident-to-resident altercations, and we have elopements, and burns, all terrible things. But it kind of gets us thinking about our systems and validating our systems and helping to work those through with our staff and help them feel more comfortable as we navigate through the public health emergency back into standards of practice. So thinking on our previous slide of how we're working through, looking at prevention and assessment and evaluations, communications and investigations, this document flows in that same manner or aspect. We start with looking at the foundational principles that we have when we look at preventing falls or trauma with injury with relation to resident care. We look at that culture of being mindful about what our hazards are in our environments and looking at those. When we're walking by rooms, are we able to pick up on things that may need to be addressed or changed? Whoops. This could be ensuring that if there's liquid on the floor or a piece of equipment is broken, are we able, as our staff, responding to that and taking those items out of service? From a staffing perspective and a morale perspective, this is a great opportunity to really build out your recognition programs. If you have staff that are identifying these changes or identifying these needs and they're following through on our process, this is a good opportunity to share with them any type of employee appreciation that you have, whether it be a gift card or a certificate, either name on the board. We had a wall that we would be our Hall of Fame people, and we allowed anybody in the building, any residents, families, vendors, staff, your peers, could write a note on what they saw that you did, and then we would draw names from that and do a raffle drawing. So it's a great opportunity for people to recognize, thank you, Sally, for cleaning up the spill on the floor and letting housekeeping know that we were going to need some assistance with some of the chemicals to take care of it. And then Sally wrote, well, thank you, housekeeping, for all your help. It's so great to work with a wonderful team. We really got some good camaraderie going and good recognition that allowed us to build on that culture and to celebrate the good things that we were doing. And when you focus on the good things like that, it just continues to breed that positivity. Thinking about how we are educating our staff on follow assessments and looking for mentoring opportunities, especially new people coming into our industry or new people coming into our buildings, giving them some of the tips and techniques and letting them understand how these pieces relate to what we do. In our pre-admission process, we want to ensure that we're asking our family members, engaging our family members and residents in their history, and then with relation to injuries or risks and safety interventions. Our families have a wealth of information, and bringing them in as our care partners that we are including them in. They're going to be able to help support us in ensuring our resident is safe, creating a very individualized care plan that's going to be effective. And if an accident happens, they're aware of what's going on and they had a voice in this. When we have families that are really supporting and positive to us, when they engage with our surveyors, they can share a lot of information for us. And I've been fortunate to have several buildings where our families were very complimentary to what we were doing and our engagement and what we were talking with them. And it was nice to hear our surveyors compliment us on that as well. We want to ensure that we're reviewing our room to promote mobility and promote independence as best as we can while mitigating any type of accident from happening or injury from happening. We're not always going to stop accidents from happening. That's just part of what life is. I was fortunate to have a surveyor in my career. As I sat down with him and said, I'm so worried that I can't stop these falls from happening. There's not much I can do. And the surveyor said, we need to just ensure that we're assessing. We have ongoing assessments, that we're using our interdisciplinary team to develop interventions. We're working with our family members, and we're doing the best we can to mitigate any potential injury from this event, because sometimes people are just going to be fiercely independent and they're going to do things that are not safe. So we have to mitigate the hazards that they have to them. The admission process, it's good to have our team thinking about what type of medications that the residents are on admission that may increase their risk of falling, and what that might look like, and so how we can implement interventions immediately upon their admission to help them for safety perspective. We want to consider individualized interventions like bed height or hip protectors or a gait belt as appropriate for individuals to minimize hazards or injuries. And this particular document, which is a QIO document, was really focused on increased observation during those first 24 to, I'd say, 72 hours. If someone's coming in on the weekend, how are we helping to put eyeballs on people that are getting used to our environment? Those transitions in care can be so confusing and so difficult to navigate. And we see more confusion as people are trying to get used to that transition and that admission level. So it's good to give more attention in that time frame to help them through that, instead of having to be reactive to situations later on. In this case, they use the 4 Ps of pain, potty, positioning, and possessions. Possessions are big, remote controls. Where is my toothbrush? I'm looking for my purse or my wallet. Possessions and where those are located and how we're reorienting people to those locations is a big deal. And making sure that when we're handing off communication for our individuals coming in to our oncoming shifts, making sure they're aware of that so they can reinforce and help to provide that comfort to our residents. So maybe more frequent checks in that time frame to ensure that their comfort and that transition is smooth. We want to ensure that we're communicating with across our teams and through that process. And ongoing, we want to be able to create that culture of safety where our staff and our team members are scanning the environment as they're walking through and identifying those risks and needs. A lot of what we see in this document really follows and is supportive of the SOM directions to us, our critical element pathway of what we should be doing. We start to see those merging of how we operationalize the guidance into what we have as center practice. We want to recognize and create that culture that safety is everybody's responsibility, just like call light response is everyone's responsibility. In my career, thankfully, I've had 3 occurrences where I've had a resident wrap a call light cord around their neck in an attempt for self-harm. And in all 3 cases, it was not nursing that was the first respondent to the scene. Twice, it was housekeeping. They saw the light come on and put their heads in to see what the resident's need was, if they could help. And the 3rd time was actually a therapist. I think it was a physical therapist, was just walking by in the hallway, saw the light come on, and just put their head in to say, if there's anything I can help you with. Creating that culture where it's everybody's responsibility and that we're all part of that same team helps to build that safety environment. We may not be able to respond to needs as an administrator. I can't help someone to the bathroom, and I'm not supposed to be ambulating anybody. But I can go in there and find out what's going on, or just check to make sure that there is safety, or if someone's up and moving, I can be there for stability and call for help while we get somebody there that's going to be able to assist them. So it is a good opportunity to just give examples on what this looks like and help to mentor. And when you see people doing it the right way, bring them back into the employee recognition and celebration, build that morale up. There's a positive to peer pressure. When we start to celebrate, people want to be part of that celebration. They want to receive that recognition as well. So we create that culture of engagement. Then as we think about what happens if an occurrence does occur, how do we do the root cause analysis, and how do we think about what our response is? In this case, the change packet, all cause harm prevention in nursing homes document gives us some recommendations on ensuring that we have processes to assess and respond immediately, that we're doing our assessments and evaluations before moving our residents, or how do we move them safely to prevent worsening of an injury. We want to ensure that there's post-fall assessments and communication huddles. There's a great opportunity that I've seen multiple buildings implement and heard about through various projects, where after a fall occurs, the people that were involved in the fall immediately have a huddle and talk about what the experience was, what they saw. When we create a culture of that quality focus initiatives, that root cause analysis, where we can talk about things and not worry about who didn't do something right. We recognize that people are coming to work to do a good job, and they're trying the best they can. And for the most part, we see that the process errors that happen, accidents that happen, are not a direct relation to an employee not doing what they're supposed to. In most cases, it's because a process isn't in place. Equipment's not available, education isn't available, mentoring hasn't occurred, supplies aren't available to them. So we think about that when we're working with our teams and creating those huddles, talking about what their experience was and what their recommendations are. Now, if they have recommendations that maybe aren't in compliance with the regulations, it's a good time to talk through what that means. I had a team member that was saying, I really think that we should put a seatbelt on in their wheelchairs so they never fall out of their wheelchair again. Okay, that's, I hear you. That's a good idea. Let's talk about the dangers of seatbelts. Let's talk about what that can look like. Do you think this person's going to try to climb out of the wheelchair with the seatbelt on, or try to duck down through it? Well, yes. So that means that that's an entrapment risk, and that could cause them to be injured. Wheelchair could fall on them. They could get suffocated. When you talk that through, my experience has been the staff go, well, we don't want that. Well, exactly. So let's think some other ideas. I like where you're going with this, though. Let's keep those ideas flowing. So keep that communication moving, and we can work through together. 2 heads are better than 1. 20 heads are better than 2. Look at how we're involving our interdisciplinary team in interventions, and how everybody has that voice, and that one department isn't overweighing another department, that all perspectives are encouraged, welcomed, and that they're heard, especially because we can see things from different perspectives, and we might have a better outcome when we combine pieces of all suggestions. We also know that the surveyors are going to be talking to our staff. They're going to be asking them. And so if somebody feels that they can't speak up because of whatever reason, then that's something we'd want to know first. I would rather know about that and work on a plan to correct that than having our surveyors know that. So think about how we do that and how we are reviewing the information after a fall at our stand-up meetings. When information is brought to the room, do we have a complete record? Do we know what our initial findings were and what the outcomes are of the ongoing investigation? What did we verify that the care plan was in place and the notifications were completed and the family is involved in the situation? And what concerns our staff had from our investigation? What was the resident trying to do? When we know what the resident was trying to do, it helps us to get to the root cause. Another opportunity is the huddles. And so we've talked about the huddles and communication. This is a tool from HQuinn that talks about how to implement huddles in an organization. And huddles are short, just like the term says, that we just kind of come together, a very short meeting, flow through some of that information, and then are able to move forward. Huddles can, in this case, our huddles are talking about what's going on with residents by exception, any changes in census that we see occurring, information about new residents coming in, news from any department that's going to be important, like maybe we're doing fire checks are coming in, the fire system checks are coming in on Friday, so all the alarms are going to be tested. I want everyone to be aware of it. Making sure we're talking about reportable events, incidents and accidents, complaints and compliments, and any other issues that we see. This may be things that are brought up from previous huddles that we can provide information or clarification on. We might be talking about the public health emergency and what information we have on that or what's changing regarding to that. Just to demonstrate, keep that flow of communication going. If we're doing a huddle after a fall or after a skin issue is, a skin tear is notified, or an elopement, then it's a good time to pull the team together and find out what happened. What do they think happened? And what was the root cause of the situation? What did they observe? And talk that through. Then we can follow up with those individuals and let them know what our intervention was and thank them for their involvement in the process. So it shouldn't be more than 5 or 10 minutes. In some cases, we recommend doing the shift change huddles. You might do a huddle based on something that's happening immediately. Maybe there's a disaster that's going on, and we're going to do a huddle, severe weather coming into town. We want people to know what the plan is, answer any questions that people have, and highlight our emergency response manuals just to make sure people know what their tools and resources are. When we do our root cause analysis, we want to get to the bottom of what happened. And generally we ask the question 6 times deep. So why for falls? Why did the resident fall? Well, the resident fell because they were trying to get up from bed. Why were they trying to get up from bed? They're trying to get up from bed because they couldn't find the remote. Why were they trying to find the remote? Well, because, so you start working that through and then you can get to the root cause and the solution. So maybe the initial intervention was to put a low bed and mat next to the floor, but we find out that the resident likes to watch the news every night at 6 p.m. And so they were looking for the remote to change the news channel. So we could either have the remote secured in a manner like with Velcro on their tabletop, or we could just have our staff be able to check in with them and make sure that the TV was on the right channel at 6 o'clock to prevent them from getting up and trying to go to the TV. Root cause analysis helps us to get those appropriate interventions in place. And if you have someone that's a frequent faller or has a lot of accidents, being able to be doing individualized interventions really helps when you're thinking about what other alternatives that we have. If we go to the common ones, then we don't always have those available to us when we need them down the road. In this case, this grid was for an example that was completed at a hospital root cause analysis. And they're thinking about what the reporting factors were, such as what was witnessed versus unwitnessed, what was the resident saying or patient saying they're trying to do, what type of injury was occurred in it, what environmental factors played into this, and what patient factors are consideration of the findings, the outcomes. When we do all of that work, we bring that into our quality assurance process improvement function. And we talk about that as a team to be able to work through what solutions that we have. We take credit for that work because it's important that we recognize, when we recognize and identify areas of opportunity, we want to make sure that we are telling our story, that we corrected it, we have identified it. So a lot of this work that we've gone through are great stories and examples to possibly include in education or orientation. It's good opportunities to share with best practices with other developing leaders or other organizations out there to help build upon that knowledge that we have. And it allows us to be better prepared when things come about. Creating that culture of survey readiness, that culture of safety really helps us operationalize our needs and focus on what we really want to do, is caring for people. We care for people who care for people. And some of the stuff is just can be a task related to it, but when we make that part of what we always do, it really helps us to build that out and really have that engagement in what we do. So I'd like to open up the conversation. What type of best practices do you have, or what kind of considerations that you've experienced that are important to note about accidents? You can feel free to unmute yourself, or you're able to type in the chat box any questions that you have. While I give us some time to chat or to type things in, I just want to go over some of the resources that we have available. Again, this PowerPoint will be sent out to you, so you do have to click on the link and be able to access this information as well. In our HQN Resource Center, we have a simple environmental safety and fall prevention guide that talks about some of the high-risk areas for fall safety, things that we can consider, and things that we've talked about in this presentation. We also have our communication and huddle strategies available. It's I think a 3 or 4 page document that walks through how to do a huddle and how to navigate through implementing those systems. And this goodie from 2018 from a Quality Improvement Organization publication, which CCME is a QIO. This is the all-cause harm prevention in nursing home booklet. It's a pretty in-depth manual. It's about 60 pages, and it highlights different areas of regulatory structure and guidance that we have. So it is from 2018 when we first had our phase 1 implementation on the SOM, but some of this is still applicable to what we do, because it really helps drive those cultures and those process points that we have in organization. It's easily navigated by tabs and focus areas. So the section on falls, I think, was 3 or 4 pages, and just some points of interest. It's easy to share with your staff as well. And for QAPI, we have our QIO resource on how to complete a root cause analysis. Some of this stuff can be scoped down. In this case, the QAPI guide gives us a bigger picture on how root cause analysis is introduced into QAPI systems and looking at process flows and process guidelines. But the characteristics or the components within it can be scoped down to using root cause analysis on investigations after falls or unusual occurrences, being able to follow that same type of methodology in a more streamlined, focused approach to get to the bottom step where we can do an implementation for an intervention. So definitely a good opportunity to take a look at how we can scope these conversations further. Gonna check back in. Is anyone interested? Have any best practices or questions or comments, even questions or comments related to the PHE you'd like to talk about?
Melissa, we're not getting anything new in chat.
Okay. Well, then let's add 5 more minutes back to our busy days. Thank you so much for joining us today. Hopefully this was good and positive information for you. Do want to promote out there that this month in March, we will have Julia Brooks coming back on to talk about rehospitalization. So stay tuned and have that on your calendar. She's always a great presenter and gives us some good information. So looking forward to seeing you guys next week. Hopefully you have a wonderful and safe week. Please stay safe and healthy out there. we'll see you around. Goodbye, everybody.